Hi, I'm Ruth O'Regan, Chair of Medicine at the University of Rochester. So the concept of neoadjuvant or preoperative chemotherapy is to downstage breast cancers before patients go to surgery. So the advantage of giving preoperative neoadjuvant chemotherapy is that you can shrink the cancer down, you can shrink the lymph nodes down, and in a fairly significant subset of patients that have estrogen receptor negative cancers, you can actually eradicate all the cancer in the breast and the lymph nodes. Now, that doesn't mean that patients don't need surgery. They do need surgery, but certainly it's possible to do less surgery. So this approach is very widely used for patients with HER2 positive breast cancer, whether it's estrogen receptor positive or estrogen receptor negative, and also in patients with triple negative breast cancer. And what we typically do is use standard chemotherapy that we would use post-operatively, but give it before patients go to surgery. In the HER2 positive setting, we combine chemotherapy with the HER2-directed antibodies. And we then obviously monitor the patients very closely using exam and imaging to make sure that the cancer isn't really shrinking. But from the older studies that we have, what we know is firstly that if patients get chemotherapy before versus after chemotherapy, they have a similar outcome. We also know that patients who achieve a good response to preoperative or neoadjuvant chemotherapy, they tend to have a very favorable outcome. So I think one of the big advantages of using preoperative chemotherapy is that it allows both the physician and the patients to know that the chemotherapy is working, because if we do it after surgery, you're essentially treating, or you're assuming patients may have what's called micrometastatic disease, but there's nothing to monitor to know whether the chemotherapy is working or not. The other thing I would say that's a big advantage of using neoadjuvant chemotherapy is it's a very useful research tool. So some of the drugs that we have are currently approved for in HER2 positive breast cancer were actually approved in patients who received it in the neoadjuvant setting, and they used the response to the treatment to actually determine how effective the drug was going to be in preventing distant recurrences. So overall, the reason that we give chemotherapy to patients with early stage breast cancer is to decrease the risk of distant recurrence. However, if you give it preoperatively or neoadjuvantly, you offer the advantage of downstaging the cancer, so shrinking it down, shrinking down the lymph nodes. You know whether it's working or not. And also, if patients achieve a complete response following treatment, their outcome is very favorable. So as I mentioned, it's generally used for HER2 positive breast cancer, triple negative breast cancer. We do use it in hormone receptor positive cancer that's HER2 negative, but typically the cancers don't shrink as much. So very often we'll send those patients to surgery first and then determine whether they need chemotherapy afterwards. So it's a very valuable tool, both for patients and I think research to kind of work out whether a drug is actually effective or not.